So I'm going to talk about emerging sleep technology for diagnosis and management of stress sleep apnea. And this is my disclosure. I've been an active member of ASM Emerging Sleep Technology Committee for the past almost 2.5 years now. So what I'm sharing with you today are some of the things I learned over the past couple of years and some of the things I've been working on the past couple of years. And I do receive research grant funding from Belong Tech company. I'll mention the Belong Ring a little bit. I don't receive any salary support from them. Got a case Taipei Medical University grant funding this year, and next year we'll be working on nightwear at VA. This will start next year. We want to talk about very quickly talk about digitalization in medicine very briefly. We'll try to cover emerging sleep apnea diagnostic tool. Mainly, we're going to talk about what is PPG. What do we need to know about PPG? What is PAT? What is the difference with PPG and PAT? We'll talk about disposable pad-based devices. There's WatchPad 1 and Night Owl Mini. And we'll talk a little bit about Night Owl, which is a new kid on the block. And we will talk about consumer sleep technology. There are ring devices, the Oura Ring, the Circle Ring, the Belong Ring, and smart watches, trackers. I'm not going to talk about wearables much today, but I just want to say that these contactless devices on the nightstand can be coupled with pulse ox in some of the devices, and may be able to give us AHI down the road. I know some of the companies are working on that. I have one slide regarding the evolution of clinical pathways to diagnose OSA. We'll try to cover therapeutic devices as well. It's getting more important during Philips recall. There are EPAP devices. There's a new negative oral pressure device, a new tongue stimulation device, and Kingman is currently working on this CNAP device. If we have time, we'll talk about it. Then we'll talk about recent proposals for better validation research in emerging sleep technology. And at the end, I'll talk a little bit about the #sleep technology website. So this is just to give you an overview of age of digitalization. There are a few things that are important. First is internet, the Internet of Things, Internet of Medical Things. This connect the wearables, and a lot of information will be sent to the cloud. The cloud can, so for example, like the Long Ring, we can upload to cloud. There will be some assessment or analysis of data, then we can download. So cloud is awfully important, and you will see that cloud is pretty much there for all the devices. So most of the devices will be connected to the cell phone, to a smartphone through Bluetooth and go to cloud. And some of the devices will have artificial intelligence. And of course, the last piece is cybersecurity, which is awfully important. So these are four important aspects in the age of digitalization. I want to refer you to this article. This is evaluating consumer and clinical sleep technologies. This is an update from our committee. There are some terms, definition of terms, and we try to, because there are so many of these devices on the market, I often say that every time I turn around, there's a new device that we can evaluate. So we try to divide these devices into several categories. The first is consumer, then the other is clinical, whether it's a consumer grade device or it's a medical grade device that we can use clinically or in research. Then there's hybrid and transitional grade devices. For example, some of the consumer grade devices, maybe over the years, evolve into clinical grade device. And then we have the diagnostic with therapeutic. We add a category here, long-term monitoring. But again, in fact, if you want to make it simple, we can just say consumer, clinical, diagnostic, therapeutic. I'm going to try to cover diagnostic and therapeutic, a little bit on therapeutic as well. We'll talk about consumer and clinical grade. So the first thing to know is about FDA pathways. I modified this slide from our vice chair, committee vice chair, Sharon Rodden. most of our devices that we use, whether diagnostic or therapeutic, in sleep medicine, most of these are FDA cleared devices. These are what we'll call class 2 medical device. The company will get a 510K or its K document from FDA. These devices are typically low risk. For example, all the home sleep apnea testing devices are FDA cleared class 2 devices. CPAP device used to be class 3. We'll talk about it now. I think 3-4 years ago, it got reclassified as class 2 medical device. So you have to use the term accurately. So for most of our devices are FDA cleared. And what is FDA approved? A lot of time we say FDA approved. These are really for more invasive devices. They are high-risk device. These are what we call class 3 device, medical grade. Inspires an example, pacemakers. These are class 3 devices. I want to make sure that you all know there's a class called FDA register. For example, you take pulse ox, for example. There's a special class called PGJ. These are for sports and wellness, and these are consumer grade. So do not confuse FDA register with FDA cleared. So if you talk to a rep, they say, oh, we have an FDA registered device. That only means they got their device registered. When you go on Amazon, there are so many pulse oximeters, and they are not even FDA registered. So one important thing to know, again, is FDA registered is not FDA cleared. And also, FDA clearance may be only for a certain function of a device, but not for all the claimed functions. For example, smartwatch, like Apple Watch, you have pulse oximeter. There you can measure pulse oximetry. You can have SpO2. But that SpO2 function is in fact not FDA cleared. But their EKG function is FDA cleared. So the other example is Long Ring. Long Ring is a FDA cleared class 2 device as a pulse oximeter. But their function for making diagnosis of OSA is not FDA cleared. They are seeking FDA clearance. Probably will be doing that soon. But again, you need to know one device may have multiple functions and not all functions are FDA cleared, oftentimes. We'll talk about wearables a little bit. There's this quote unquote quantified self movement. We can quantify ourselves. So there are smart watches, smart clothes, there are also smart devices. And basically these smart devices or these wearables can communicate with your smartphones through Bluetooth, then through Wi-Fi or through 5G, can eventually go to cloud, as mentioned. And then information can be shared with the providers as well. That's most likely going to be the trend. And eventually, it can possibly even be integrated into the EMR system. There was an email coming out where we had some discussion in our committee trying to find out whether there's any wearables that may be currently connected to EMR. So we had a little bit of discussion on that. But the important part is that wearable technology involves acquisition of data. On daily activity, these watches, these devices can give us some idea about our daily activities, sports performance, and health status. And so the hope is that it will enable monitoring at-risk patient intervening disease at earlier stage and potentially reducing healthcare costs. This remains to be studied. And I just want to mention very briefly, these are electronic tattoos. You can put electronics at the back of tattoo, put it on patient. In the past 10 years, there's an area called epidermal electronics or epidermal sensors. These are hair-thin, lightweight, stretchable circuits. These are, in fact, are self-powered. I don't have a whole lot knowledge of this. I just want to tell you that this is a very active research area among engineers, researchers. So what can wearable do? Wearable can give us actigraphy through accelerometer and sometimes through gyroscope as well. PPG, EKG, EEG, respiration, and there are devices measuring electrodermal activities. There's a device called Ambrose Chiang. I'm not going to talk about the device, but that device can, if someone has a grand mal seizure, this device is clear for age 6 or older for grand mal seizure lasting for 20 seconds. They can notify providers and parents and so on. So there are all sorts of devices out there. And just to give you some example, this is a device for PPG that you can put in ear canal. This is a device called Morphia. It has a PPG, has an accelerometer, put on nose bridge. They claim that it can differentiate central from obstructive apnea as well. This is an EEG device, electronic tattoo for, I believe this is for EKG. This is a ear canal device that you put in the ear canal, you can get EEGs. And these are, this is cap for EEG, this is monitoring around the ear, some leads there, and monitoring EEG as well. So these sensors can measure quite a few things. I'm not going to be focusing on actigraphy alone. I'm basically going to be talking about obstructive sleep apnea. So PPG is important. Actigraphy is in a lot of these devices. So we'll mainly talk about the sleep apnea wearables. Let's talk about PPG real quick. PPG is the optical technique that measures volumetric variation in circulation. So this is the curve that you get. This is what you see on pulse oximeter. And on the PSG montage, you will see this as well. So this is from the pulse oximeter. So when you read about PPG, you will see them talking about AC signal and DC signal. AC signal means they're talking about this pulsatile arterial blood volume. Then they are the DC signal for non-pulsatile circulation. There's a new book just came out last week. If you're interested, this is called photoplethysmography. There are a few things to know. The greater the blood volume will result in higher light absorption and lower light reflection. We'll talk about absorption and reflection a little bit in the next slide. But it can measure SpO2. It can measure heart rate variability, respiratory rate, blood pressure, heart output. ANS function can detect atrial fibrillation, arterial stiffness, atherosclerosis, and PVD. But I'll say that a lot of these functions, in fact, are not, the measurement is not that accurate, and the technology is not really mature. For example, some of the devices claim that very soon they can measure blood pressure, which is questionable. But you can now measure, of course, SpO2 and heart rate variability and AS function reasonably accurately. It's important to know that there are different light that are used: the red light, infrared light, and green light. Some of the devices that all of them. The red and infrared light are typically used for medical grade devices. Now they penetrate a little bit deeper and get better data in terms of vascularity and volumetric circulation measurement. The green light, however, is more commonly used in wearable devices. Most of the cheaper wearable devices, they have only green light. And this may be affected by skin tone, and it's important to know that. And the red and infrared light sensor are less affected by skin tone and more accurate than green light. And but they have more motion artifact. Now, what is PAT? What is PAT signal? In fact, PAT signal is enhanced PPG signals. So traditionally we say, well, PAT, every time we talk about PAT signal, we think of watch pad. But watch pad really acquire and enhance PPG signal through their finger probe. So there's this finger probe with a hard shell, and inside there's pneumatic cuff. So after you stick your finger in, this cuff provides a constant pressure throughout and avoid venous pulling. So that this gives give us a very good PPG signal. This is what PET is. And Night Owl, which is new on the market, they claim that they can achieve the same signal through their proprietary patent pending software, and they use the algorithm to achieve that. So PAT or PET signals, in fact, enhance PPG. The measurement size really matters. I'm trying to show to you that finger, earlobe, and forehead, in fact, can give you fairly good signals. The rest of the places probably not so great. You can measure it through the forehead. There are two kinds of PPG measurement way of measuring. One is using absorption or transmission technique. The other is using reflection or reflectance technique. So you have, for this, you have light source at one end and photosensor at the other end for reflectance. They're at the same end. So it's important, and by the way, there are others, as we mentioned, talk about these, and this is a urocanal one. And there are ones that measure from mastoid. They put in a cup and put in a helmet, and for a jet pilot, you can monitor their PPG and heart rate variability and so on. But the signal strength, the best place is fingertip. That's why Night Owl and watch pad give you very good signal because there's very high density of arterioles and capillaries. And similarly, in earlobe and forehead, you get a high density of vessels as well. Now, low PPG amplitude may be due to less vascular density. For example, that's part of the problem with smart watches because the back of the wrist is not a place that has a very high vascular density. On top of that, for the watches, sensor contact is a problem. You wear a watch, it cannot be too tight, which is going to be uncomfortable. But if it's too loose, you're not going to get good signals. The other thing is arterial pulse pressure amplitude. You cannot do it on radial artery because it pulsates too much and give you a lot of noises. And there's a device called oxytone, which was used in loft atrial trial initially. I tried it out previously in an investigator meeting, and it's very difficult to catch that signal. And ulnar artery pulsate a little bit as well. But anyways, there are many different ways of measuring PPG these days. I'm not going to go into this too much, heart rate variability, just for you to know that PPG can provide this. And it's important to know probably these terms: high frequency, which indicates parasympathetic activity; low frequency typically indicates sympathetic and parasympathetic activity, or some of the folks believe it's mostly sympathetic. And low frequency or low high ratio, which is the sympatho-vagal balance. And in fact, a lot of consumer products try to provide this information. Then they have different ways of scoring it. We don't have time to talk about it. And there's a very low frequency. But overall, these things change with age, and in most of the sleep disorders, there is a decrease of high frequency or parasympathetic activity. I want to mention very quickly, there was one study, system review, looking at correlation between classic EKG-derived HRV and wearable PRV, the pulse rate variability here, from very good to excellent during rest. Again, all of these, whether SpO2 or heart rate during exercise, even though they can do it, it's going to be very difficult because there are going to be so much noises. And there are what we call time domain, frequency domain, measurement of heart rate variability. We don't have time to talk about this, but we talked about it a little bit last few months ago, but we're not going to go into it. We'll talk about individual devices very quickly. WatchPad, made by Admar, and recently there was a news that Zoe is going to acquire them. This is WatchPad 100 from about 15 years ago. At VA, we're using WatchPad 200, and there's a WatchPad 300 device with substernal sensor. And this substernal sensor gives us the snoring information, gives us respiratory effort and body position. it is claimed, and there was one study about studying about central apnea's industry-sponsored study. Personally, I think the central apnea function is really not, detection function is really not that great, because when we sleep study, we see a lot of obstructive events were misscored as central. But this is the disposable device, which is fairly popular during COVID. And again, this is to look at the vasoconstriction-induced PPG signal change. So when there is an autonomic arousal from that can lead to sympathetic activity change, and this is basically vasoconstriction. That you can see this signal here. There's a drop of PAT signal. This is the amplitude of PAT signal, and this is heart rate. So if there is a 30% drop of amplitude, a 10% increase, then they call it a reciprocal change. And if there is this associated with SpO2 drop, then it will be kept as an obstructive event. They have these rule-based, it's called rule-based algorithm. So they have automated scoring following these rules. We don't have time to go into the rules, but they have these rules. WatchPad is not AI-based device, but you can manually score it. And for the WatchPad 1, which is disposable device, you need a smartphone, Wi-Fi, or internet. A few years ago, we all thought that is fairly good, but there was a study from last year from Atlanta, VA, with 500 VADs underwent concomitant PSG and WatchPad. And their result was a little bit surprising. It was really not as good as we thought. I don't remember these, which one's 3% or 4%. I made this slide a while ago. And this is almond plot, and this is scatter plot, and you can see that there are still quite a bit of scattering here. The problem is the diagnostic concordance, which means if you get to put into mild category by WatchPad, whether it is mild on PSG. So if you look at mild, it's only 42%, moderate 41%, severe 83%. So accuracy was not really that great. And for 3% of use 3% hypotonia desaturation criteria, WatchPad will overestimate by 4, and using 4% criteria, we use it at VA. We will be underestimating by 6. So the problem is that if you get diagnosed with moderate to severe OSA, 5% may not even have obstructive sleep apnea. If you're in mild obstructive sleep apnea category, 20% may be moderate to severe, which is not so much a problem. But you have no OSA in about 30% patients. So the conclusion from this study was that patient without OSA obviously should undergo a repeat PSG, but those with mild disease probably should do that as well. So currently at a VA, we're not retesting mild obstructive sleep apnea, basically use clinical judgment and make a decision what to do. And a lot of time we're still training these patients, because during COVID it's very difficult to get patient in for PSG. But this was published last year. So I think it's an important article that you may want to go look into it. Now this is Night Owl. Night Owl device is very small, and as you can see here. Using tape it up. This is the reusable device. This is their disposable device to give you 10 tapes to tape it up. It is FDA cleared for a class 2 device for diagnosis of obstructive sleep apnea. It was just cleared last year. And reusable device, you can do 7 nights, Night Owl Mini, which is disposable device, you can do 10 nights. And again, it's using PPGs and accelerometer. And we talk about is using software. There was a study published in 2018 on Journal of Sleep Medicine, and this was their data. And this is the Night Owl REI, and this is a manually scored AHI, and the correlation coefficient is 0.77. Some scattering there, and this is total sleep time correlation here. Again, this is a rule-based device, not AI-based. Compared to WatchPad, central apnea detection function is not there because there's no body sensor, and raw data review is not yet available, so it's all automated. And just to mention that ActoSense, this company in Belgium, who started this night owl, was recently acquired by ResMed in October, just last month. And I'm going to talk about Belong Ring a little bit. We'll talk about the ring devices. Belong Ring is a device the company is in Hong Kong. It's a startup company. It is, as I mentioned earlier, it's FDA cleared class 2 pulse oximeter. Not their OSA detection or diagnosis function is not approved. My understanding is some of our data will be used for approval, and Stanford is doing another study, and those data will be used probably for application. And we did 2 studies, and Eric was involved, Eileen was involved, Zach Strom was involved in these 2 studies. Now, Belong Ring use neural networks, so capture PPG SpO2 accelerometry. I'm not going to go into detail. They have AI algorithm. In fact, they have a lot of subjects and a lot of records. At one time, I asked them, where do you get all of those subjects? They, in fact, use most of these subjects are based on the sleep heart health study. The raw data were available for them, and they built their model and trained using mostly the sleep heart health study information. We had 2 studies. I'm not going to mention the last one. I'm just going to mention the latest study result. This was an ACP abstract that we presented, Zach presented last month. So this is the blank almond, this is scatter plot. This was our interim analysis. We're still trying to analyze all the patients, and Eric is helping as well. So interim analysis, we had 48 subjects at a time. BMI was pretty high. All was stop anchored, and 3, there was no AFib or heart failure patient. The device does not, it has a little bit of problem with central sleep apnea, but their next generation device will probably be better. We'll talk about it a little bit. But there are a correlation coefficient with the AHI correlation coefficient was 0.86. The accuracy based on cutoff AHI 15 was reasonably good, and accuracy for AHI greater than 5 is not that great, but was this is the second generation algorithm, but this was much better than first generation algorithm. The second generation algorithm also give us RAM, non-RAM, and wake and ANS function, and they have a new ring. And the new ring will be coupled with a wireless body sensor, which is a subxiphoid sensor. And this will give us temperature, the respiratory effort, and body position. But no snoring. The company felt the snoring is probably not going to help, probably will create a lot of noise, so they're not adding that. And we're planning for a study to compare with WatchPad against PSG at a VA. And for screening, this is for diagnosis, but for screening purpose, the recent approved grant from Case and Taipei Medical Universities is to try to screen patients for ischemic strokes in Taipei. And there are a couple of other studies being planned. One is to study screening outpatients with obesity and hypertension, the other is to screen patients with metabolic syndrome. And I just want to thank Eric and Eileen and Zach as well for being very helpful in making this study work. And Oura Ring, very briefly, I'm not going to go into the details. You all know, probably should know what Oura Ring is. It's a very nicely made ring. This was from a company from Finland. They provide a PPG information, temperature sensor, accelerometer, and gyroscope. Gyroscope is a way to detect the rotation and orientation of a patient. and can make actigraphy a little bit more accurate. I think an important part is to know that they do have machine learning algorithm, and they can try to detect, differentiate light, deep, and REM sleep. Not that great, but this is in fact a very decent device. But they do not have SpO2 information. You can do wireless charging. They have their own cloud, their app, and so on. This is typical for all the wearable devices. There are multiple studies now. A couple of years ago, there was a study in 41 healthy adolescent young adults, very young age, with 96% sensitivity in detecting sleep and 48% specificity in detecting wake. In fact, this result is not bad, but the limitation of this study is these are healthy young population. But again, I want to mention that this is very typical for all the wearable devices to give you sleep stages. These are typically, if there are studies done, most of them don't have studies done. But if there are studies done, they're typically in healthy population. They're typically not in patients with sleep disorders. So it's important to know that. But there are multiple studies now on healthy individuals using our ring, and the results seem to be decent. There's another device called Circle Ring, and now they have their second generation Circle Plus ring from Body Metrics. This is a device, my understanding, made in China. A very nicely designed ring. In fact, they are springs on these sides, so there's no need to size the ring. It's just all one size fit all, basically. And the Circle Plus ring had this extra part on the other side. I'm not showing to you, but there's a little metal part that when you wear the ring, you can use the other hand finger to touch that metal part. You potentially can get EKG. I'm not going to have time to go into all of these details here, but I just want to mention this is an FDA registered pulse oximeter. It's not FDA cleared. You have to go through a very difficult process to get FDA cleared, because you have to do put patient in the intensive care unit with arterial line, measuring all the oxygen saturation throughout the night, and send information to FDA to make sure the wearable device is good. But again, this is going through the code PGJ for wellness and sports. And this device was in fact available on Costco. I saw it on Costco, and it's now available on Walmart, the Circle Plus. It's kind of a hybrid device in a way that is not cleared by the FDA here in the United States, but the Chinese FDA cleared the device. And they have the red, infrared, and the green lights there. And the same principle, they claim they're the only ring oximeter with continuous SpO2 and heart rate tracking for fitness, sleep, and overall wellness. Again, I want to mention this: during exercise, the data are really not accurate. So the fitness data, there are folks doing studies, but it's fairly difficult. There are a lot of noise there. But in the future, they claim they will be able to do EKG, as mentioned. They claim that they will be able to measure blood pressure. But I very much doubt that, because my understanding, this has been studied for many, many years, and it's still far away from perfect. There was a study done. You can see the blank Altman, but it's very odd. It's not scattered, but they seem to be overestimated under a lower pressure range. And this is for normal individuals. So you can imagine if you're trying to measure these for a patient with hypertension. I'm not sure what's going to happen, but there are a lot more research and engineering need to be done. I want to mention very quickly on wrist-worn sleep trackers or smartwatches. This is Apple Watch. This is the oxytone device I mentioned earlier, measuring ulnar artery region. But the these consumer sleep devices, probably the best is to alert physicians maybe about sleep apnea risk. There was a talk on disruptors, 2019 ASM disruptor lecture, and Fitbit researchers were talking about their device. Again, I mentioned the technical difficulty with these watches because of less vascularity, poor contact, and hairs is also a problem. So none of the smart watches are cleared by FDA for SpO2 measurement, and you need to know that. So even though they give you that information, they're just for sports and wellness. They're not really good in measuring these SpO2. And there was one, by the way, I should mention, there was one study from a few years ago looking at those pulse ox from Amazon. There was a study looking at it. They had some concern because SpO2 under 90% does not appear to be as accurate. And again, skin tone is another issue. And even heart rate can be an issue. There was a study showing that the PPG heart rate can occurs up to 15% more frequently in dark skin compared to light skin. So inaccuracy remains a concern even for heart rate. Some of the manufacturers recommend even using the device only in light skin tone or at rest. Some of the devices has added red and infrared sensors like Apple, Garmin, and Xiaomi. But there are definitely a need for validation study. A lot of these, most of these devices are not validated. And for the manufacturer, there are questions: how do they communicate with consumers and how to communicate the findings with providers and so on. There is one device I want to mention very quickly. This is a sleep image system. I'm currently reviewing this for the committee. This is a device which is very interesting. If you've been in sleep medicine for some time, you know this term called CPC, cardiopulmonary coupling. It's a little bit difficult to explain, but again, you have the heart rate variability that they're trying to study. You have the breathing, the respiratory variability they're trying to study. And they can put it into a 3D spectrogram to look into these changes. It's a little bit difficult to explain, but this is what they call the high frequency coupling. And this is the blue here is the low frequency coupling, and the yellow is very low frequency coupling. And this coupling can give you some idea about sleep. So high frequency coupling indicates stable non-REM sleep, typically N3 with some N2. And low frequency coupling is low frequency coupling with indicating unstable non-REM N1 and part N2. And very low frequency is either wake or REM. And they have the pulse ox now. So they now have a device, but this is interesting. I have some concern about this. And I just talked to the manufacturer, their CEO, last week. This is a classical example of FDA cleared cloud-based software as a medical device. So it is only the software is approved, and please know that it's also approved for children and adults for diagnosis of sleep apnea. But there's a problem. All the studies they publish, they are all using PSG. For example, PSG is non-in pulse oximeter. They're basically using the non-in pulse oximeter during PSG to compare with the PSG AHI. So there's some problem because you're not using your own hardware. So basically, what they're trying to do is they are working with this company called Viatone, which produce a similar looking ring called wearable ring. Wearable ring used the wearable app, and the sleep image system ring used the sleep image app. So they are trying to find hardware to incorporate their software on hardware, but the problem is hardware is not tested. So I have some question, and this is the concern, but you should know this term cardiopulmonary coupling, and you may want to look into it a little bit. But they claim they can differentiate obstructive sleep apnea from central sleep apnea with spikes on the spectrogram and obstructiveness, broad spectrum. So Robert Thomas from Harvard has studied this for many years and is still publishing on this. To give you a summary on this, the pros and cons: low cost, easy to use, there's no wire, the sensor can be embedded in watch, cloud-based app availability allows study for multiple nights. You can monitor progress of treatment and reasonably accurate with AHI greater than 15. In some of the devices, I should say, in some of the devices, a lot of devices that may not be tested, even though they may have the function. The high motion noise, low perfusion in some sites is the problem. Direct contact is the problem. Concern for inaccuracy due to dark skin tone is a concern. Probably more accurate again for AHI greater than 15, but not so great in differentiating no OSA to mild OSA. And may overestimate, underestimate, may, depending on the criteria you're using, may not differentiate central from obstructive. If there's an AI system, there will be concern of data shift, which means there was a letter to the editor on New England Journal of Medicine a few months ago. And this data shift is something that when a system underperforms because there's a mismatch between the data set, which is development data, which is deployed. And the other problem is that these are all black box tools, proprietary. They won't tell you what they were doing, and the lack of interface for raw data for review is another problem. Very quickly for this, different eras, there's some evolution here. So traditional in-lab, back in 80s and 90s, and before 2008, you have face-to-face in-lab study, put patient on fixed CPAP, bring them back and adjust. Since 2008, out of facility model here, in initial face-to-face, home sleep testing, negative go to in-lab study, or then you put patient out of CPAP with download and with face-to-face follow-up. After COVID, we're doing virtual visit, home sleep testing, again, similar algorithm, but doing virtual visit. And this part was from Sam Kuna. He gave a nice talk on telemedicine, saying that telemedicine is here. But I added this part. This part is the telemedicine with emerging sleep technology and home sleep testing. So we may end up a few years down the road, we may end up doing virtual emerging sleep technology from patient, which could be consumer or clinical grade. And we may still do some home sleep testing. And if there are questions, go back to sleep lab. And these emerging sleep technology can possibly be used for follow-up. And of course, if there are questions, you bring patient back, try non-CPAP alternatives. Now, I don't have much time now, but there are still quite a few slides in terms of therapeutic options. I'm going to talk about these very quickly. You probably recognize many of these treatment options, but there are a few new ones here. I want to talk very quickly about INAP, which is an active oral pressure device, which is here. Daytime tongue stimulation device, Excite OSA, some EPAP devices, and CNAP or air sleep. This one is not FDA cleared, the rest are all FDA cleared. Before I go into that, you need to look for supporting data. There was a good review from American Journal of Respiratory Care Medicine last year. So there are a lot of noise. You have to be very careful because a lot of even FDA cleared device, there are no data or very little data. So you need to look for evidence. And the common problem is there's no evidence. You need to, when you are considering using these devices, you need to consider whether studies are industry sponsored. Does not mean it's a poor quality study, but you should still know that. You need to take a look at efficacy, whether AHI decrease, ODI improvement, how much improvement you see there, oxygen saturation upward, and some of the questionnaires, whether they are symptomatic improvement or not. Number of subjects, typically there are small numbers of subjects, whether it's limited in thin patients or in mild sleep apnea patients. So you need to take a look at the design. Are there randomized trials, sham, device, crossover, inclusion, exclusion criteria, subgroup analysis, or in specific population. Some of the devices may need time to get acclimatized. Is there a period of time? Because when you prescribe it, you need to know that information, tolerance, long-term follow-up, adherence. Is there any imaging study, physiologic data, pediatric indications? These are all important. I want to talk about INAP very quickly. INAP is a very interesting device. You may recall Wink's device from a few years ago. Rinks came on the market, I believe, in 2013 and went out of the market in 2017. In fact, a company called Epicure was acquired by Sonics, which is making INAP. So this is a Taiwanese company, and this is the device. And it is FDA cleared class 2 for mild, moderate, and severe, so all severities. And Winks, by the way, has shown that it can reduce AHI by about 50%. Now, the difference of these two devices, one of the important differences that is portable, and Winks is not. It's battery powered. You can charge, and you have a battery there. And I don't remember how many nights you can use it, but basically create an active intraoral pressure. So there is a portable console. There is a little chamber here that you put a little pack in. And because when you put this in the mouth, it will suck saliva into this little container there. So there's a little pack with a saliva absorbent pad. So in the morning when you wake up, you take it out, you're not going to have saliva floating in it. It's all absorbed in that pad. And so you just throw the pad away and pack away and put another one in the next night. And there's the mouthpiece is different. It's a polymer oral interface instead of this. Winks is a hard plastic kind. There's an app, and you can track usage and seal time. Once it's sealed, the machine kind of is in idle. And the other difference is they have higher negative pressure, -40 versus Winks, which was -20. And they study on a few patients. In fact, you can see this -20 pressure, it really does not change AHI. That's the problems with Winks. I used it between 2013 and 2017 on a few patients, and I had no patients who claimed this is helpful. That's the problem, because they have a 30 days money back guarantee, so a lot of patients just return the device. You really need more than 30, pressure of 30 to drop the AHI in 4. So this is what they put pressure of -40. And it's cloud connected, and the information can be sent to providers. And this device that has the most studies, or 5 industry-sponsored studies, but unfortunately, all the published studies are on Asian patients, 3 studying Taiwanese patients and 2 studying Japanese patients. These are thin patients, but they can lower the AHI and Epworth. There was 1 study on Epworth showing improvement, but these are all non-obese. So they really need to do more study on varying patient population. There was 1 abstract from Germany, but more research are needed here. So they did an imaging study showing that there's a greater ability to widen retropalatal region. And good candidates are those who can give a stable vacuum, and a poor candidate are those who cannot give you good vacuum and have significant sinus congestion, because you won't be able to breathe through the mouth. So you really, if you have significant sinus congestion, you will have problem breathing. And adverse effects, mouth dryness, saliva getting very thick. And this is some of their data. They're showing that this is a Taiwanese study showing that for moderate sleep apnea, they can drop an average AHI of 23 down to 7, and in a severe patient can drop from 42 down to 11. So with some significant improvement, but larger, longer-term studies controlled with sham device will be needed and in various populations. Very quickly on CWRU, this is mainly a device for snoring and mild obstructive sleep apnea cleared by FDA for these 2 populations. It's a daytime treatment modality. So use it while awake, and at night you don't have to wear anything. So there's a mouthpiece here, there's a control unit here. they have an app. The stimulus intensity varies from 1 to 15. And it's cloud-based. You can measure the adherence to patients using it 20 minutes every day. The protocol is that you use 20 minutes once a day while awake for 6 weeks and twice a week thereafter. There are 3 industry-sponsored studies showing that it can help snoring, but not a whole lot of data on AHI. There are 2 studies showing AHI data, but seems to be able to decrease AHI, ODI, Epworth, and PSQI in mild OSA patients. So one study with 38 patients, AHI dropped from about 10 to 5. Epworth dropped from 9 to 5. Another study, 65 patients, AHI dropped from 10 only to 7. This is unpublished study that a company sent to me. They typically exclude obese patients, BMI greater than 35, in one study 32. There was no sham control in any of the studies. There are issues: excessive salivation, tongue tingling, discomfort, dental filling, sensitivity, metallic taste, gagging, tightness in the jaw. There was one study, kind of interesting, unpublished, 20 patients, funded by Inspire, recently submitted to JAP, did not show an obvious impact in genial process activity, but small number of patients. This is unpublished data. Don't have time to talk about Provan. I think most of us know Provan very well. They were approved by FDA for all severity of OSA in 2008 and discontinued in 2020. I don't have much time left. I just want to mention very quickly, probably better used intolerant to gap without electricity or short trips away from home. Most of my patients using this before I was at VA are traveling patients who want to try something different and don't want to bring the CPAP device. Probably better for mild to moderate disease or position OSA. So we have the bungle. How much data information do we have on bungle? It's FDA cleared device for mild to moderate OSA. It's a reusable device that has a little valve inside. There are very little data. Just to mention, there was only one abstract with 10 patients with mild to moderate OSA, and AHI dropped about 50% from 15 to 7. And this is the only clinical study, and it's not fully published. But there are some laboratory study bench testing showing that they have a lower expiratory resistance compared to Provan. As a result, you can probably imagine the EPAP they generate may be lower than Provan. There was one study, again, a bench laboratory testing showing that the pressure generated is equivalent to Thorovan, which is used for snoring. And this is the study. We're not going to go into that. But just to mention that when you use this device, you don't want to use it in patients with COPD or asthma because they need time for exhalation. And this will inevitably increase exhalation time. And those folks who have a lot of sinus congestion may not be a good candidate, and you need to give them 1-2 weeks for acclimatization. Again, this really we use a lot during COVID, during the recall, because at VA we have very few devices available, so we try to use more in mild to moderate obstructive abandoned patients. And I recently pulled the data. We have more than 30 patients in the past few months, and we're going to try to review this to see how many of these folks can tolerate the device and how well they're controlled. I have one patient who is still dropping oxygen saturation to 26% despite WatchPad, despite bungle, and we were following these patients with WatchPad device. And whether these patients should go to AutoPad, using AutoPad as a rescue. So AutoPad is designed by Jeff Sleeper. His last name is Sleeper, and he is a respiratory therapist, used to work with Hingman, and the company is called Briggs Medical. And this is the device that looks like a nasal pillow with a little bit headgear. So when you breathe in, there's a valve that collapses, so the air passage, so breathing in is not a problem. When you breathe out, this valve will inflate, and you cannot breathe out from the main pathway, but there's a tiny little hole here. You can breathe out through that little hole. So this was cleared by FDA for mild to moderate OSA without any clinical study. Now you may ask why FDA is doing that, because their predicate, Provant, was showing we had data on Provant, clinical data on Provant. And white paper was to that Mr. Sleeper did was to show that in a certain flow range, flow rate range, you can achieve pressure similar to Provant. And Bungo is right here. So Bungo is probably cannot get a very high EPAP on Bungo. But just to mention that there are a lot of research needed. And Dr. Stroh recently did a little bit in vivo testing on himself. But again, there are no clinical trials, so this is there's a need for that. And I tried it, and it's a little bit difficult to tolerate compared to Bungo. And I think tolerance may be an issue. We'll have to find out down the road. There's one more device I'm trying to go over. This is Somnera, used to be called Fresca. And it looks like CPAP, but much smaller. The most important thing is that they have a smart valve on their nasal mask or nasal pillow. They have a small tubing, no humidifier. So what's happening is when you inhale, you can bring in room air. Then if it's not enough, machine can provide a little bit air. During exhalation, there is a valve. This is on the mask. There is a valve that is closed. So because the valve is right on the smart valve is right on nose mask, so the pressure can increase very quickly to the desired pressure. And the pressure can be controlled. Some of the air can still come out from the side. And they use a swing door analogy, meaning it's when you're exhaling it, almost like someone's putting a door on a swing door. So that door cannot swing anymore. So they have shown in a couple of abstract, not fully published, that they can bring down AHI just like CPAP. So they are cleared by FDA for mild, moderate, severe disease and intended indication of CPAP intolerance due to excessive flow and pressure. If you have patients who cannot tolerate flow and pressure, you can probably order it through certain pathway. You can go online and take a look how to order it. So the key is that smart valve in nose masks or nose pillows. And they are cloud connected, they have smart app. There are 2 abstracts published, one on 25 patients or 147 patients, showing that using this, it's a non-inferiority trial compared to CPAP. But more research are needed. I'm going to skip air sleep. I'm going to come up with a conclusion here. That how do we, I made this algorithm. It's not perfect, but I think for mild sleep apnea, you can consider no treatment if there's no symptom of saturation or symptoms. So you can consider CPAP or non-CPAP therapy. If CPAP failure can come to this path of positional therapy, there are many devices. EPAP, for those folks who don't have a history of COPD or signal sinus congestion, you can go to these devices. You can try oral appliance or INAP. You can, if they all failed, you can try these devices, including side OSA and mild OSA patient. There are other treatment options. For severe OSA, CPAP, first high BMI bariatric surgery, EPAP. You can still use Somnera, which is approved for severe sleep apnea as well. And you can try INAP, which is also approved for severe OSA. And then Inspire or other form of surgery. This algorithm is based on limited data, not sure about combination therapy, and not sure about the role of phenotypes or endotypes. I'm running out of time, so I'm going to just to mention that there are a couple of studies about validation research. The most important thing is that the gold standard ought to be in lab PSG. You cannot compare with home sleep testing, which is not gold standard. Manually scored PSG is important. You should use double scoring. Should do by epic comparison for sleep stages, and you should describe your demographic information. So validation study, there are some requirements there. This is an important article for folks who are interested in doing validation research. And this is another article, study design consideration for sleep disorder breathing devices. I'm going to skip this slide. I just want to mention at the end, there is, our committee has, our name has emerged just like the technology has over the years. Right now it's called Emerging Sleep Technology. We have a website called #SleepTechnology. If you go there, put in the name of the device you're interested in, you will see the name. Then you click on name. There are a lot of information provided from summary to claim capabilities from the company, mechanisms, sensors, technical consideration, publications. You can find publication, click and open publications. Your FDA status there, the platform, whether it can use in Windows, iOS, Android, classification, keywords, and so on. This is the montage article, just got published in a couple of weeks ago, early. And there are these 5 different devices I talk about. And this was from our committee. And then you can go to ASM, the website you sign in, go to clinical resource, #SleepTechnology. You will see all the things that we have done and all the publications, montage articles. There are #SleepTechnology website, blog, all the informations. And I recently did an ASM Talking Sleep podcast with our chair and vice chair, and Steve McCosla, and it's there as well. So just to summarize, CST, consumer sleep technology, is rapidly advancing and potentially can provide ability for us to diagnose and monitoring treatment efficacy at low cost and fast, efficient way. Unfortunately, currently it's largely unregulated, but few devices are validated. But multi-sensor and AI-based devices will advance the accuracy in the future. Need to be able to differentiate FDA cleared or medical grade or consumer grade device, FDA registered or not FDA registered at all. So need to understand difference of these. And it's important to note mechanisms, sensor capabilities, limitations, the accuracy behind each technology. And more research are needed for validation and for clinical trials. This is a low-hanging fruit area for folks who are interested in doing more research. And for fellows, for everyone who try to use these devices, you need to look into the supporting evidence and publish trials before you adopt new treatment, new devices. So this is it. Sorry about running over time here. This is trying to just give you a quick summary on this. Questions?
Thank you so much, Dr. Chiang. Go ahead.
Real quick question, 2 quick questions. So I guess one of the issues that I have, I don't know if everybody else has, I'm sure they do, is just sort of what dose of sleep are patients getting? Is there a single device, sort of a poor man's actigraphy, if you will, that I could use, to say, so I could have some objective measure of how much sleep patients are getting? That's one. The other issue I have is, the Epworth Sleepiness Scale score is a subjective score. So I'm always trying to figure, is there a way to objectively measure, besides doing an MSLT, someone's true level of daytime sleepiness? One of the things, there's different sort of portable EEGs, you had in your talk, and that that we have in neurology. And one of the questions I have is there a way to do sort of a portable MSLT? We can measure all sorts of things now that we couldn't, say, 10 years ago. So I'm just curious, I don't know if the device exists, but for those 2 issues, because those are just difficult issues that I find when I'm taking care of patients.
I'll just quickly answer this. There was an article just published this year. This article was presented last year in Sleep. I think the first author is Chinoy. I can send you the article. He compared 7 different devices, including, I think, 3 wearables, including S+ device from ResMed. Aura Ring was there, and Aura Ring, in fact, is a fairly good device as a standalone sleep tracker. The other device that was very good was Fitbit. So the best two devices, consumer grade devices, that can give result as good as ActiveWatch. My understanding is either the Fitbit or the Aura Ring. So you should look into those. I can send you the article. I think it's a very important article because some of the parameters compared to ActiveWatch against PSG. In fact, some of the parameters, a couple of devices are very good, and there are certain things they measure are even better than ActiveWatch. That's the first thing. And the second thing is like MSLT. I want to caution you one thing, that those RAM and non-RAM measurements can be difficult. So if you look at all those RAM, non-RAM measurement, they are not that accurate. They are certain devices that may be more accurate than the others. So I think for measuring like MSLT using wearables, I think that is not practical, at least not at this point, because the measurement of RAM and non-RAM or light sleep, deep sleep, these are still not that great. This is my understanding, just to give you a quick answer to that.
Great, thanks.
Any other questions? All right, I'm not sure if Kingman's still around. Kingman?
Yeah, Kimman's around, but he's at the VA, so the mic is not
Okay.
working so well. He's trying to log in, but thank you so
All
much,
right.
Ambrose.
If there are,
It's really helpful.
if there are questions, feel free to shoot me an email. Yeah.
Sounds good.
All right. Thank you so
Quite a
much.
few questions in the chat that I thought would be interesting to have answered.
Oh, are there questions? There are a lot of chat. Sorry, I was not monitoring it. Can someone tell me real quick, what are the questions?
I think Dr. Patil started with way back at the
Go ahead.
beginning with a pleth question. Could pleth be compared to PAT or a surrogate?
Which one? Circle? I'm sorry, I can't.
Dr. Patil's comment, question.
What was the question exactly?
Always been curious if the pulse ox pleth is a reasonable surrogate for looking at PAT signals.
Pulse ox basically give you the PPG. The accelerometer give you the sleep stages, but sleep stages is in fact a little bit more complex because even let me show you one slide here. So if we look at the total sleep time, for example, like the ring device, because it's an AI device, there are a lot of parameters they are looking at through all the PPG signals. So PPG signal, in fact, give a lot of information. Heart rate variability and actigraphy. For that, you can achieve the total sleep time. For REI, you need saturation, of course, and the ring TST. So for the pulse oximeter itself, to give accurate information, you really still have to have the accelerometer or actigraphy to go with it. Without that information, you cannot get accurate information for AHI. Am I answering the question?
I don't think we're quite on the same wavelength. But again, not my question. I think he was just curious and placing in the chat for thought whether the pulse oximetry plethysmography signal could be a reasonable surrogate looking when compared to the PAT signals.
Well, that is the first thing is there are so many different pulse oximeter. For example, high-end pulse oximeter like Nonin, these are FDA cleared pulse oximeter, and those are quite accurate. The non-FDA cleared pulse oximeter is not going to be that good. And again, I don't think there are clear studies. You can get ODI, but the signals, whether it's as good or not, I'm not sure I can answer that question. But because these are not augmented signals, probably subject to more motion artifacts and so on. Yeah.
All right. And I think there are 3 questions there that are real quick, and I think probably easier to answer. And obviously, Anna was asking what other emergent devices are available at the VA other than the bongo, but you can answer that in a bit. But Dr. Ockley had
AutoPAP is available at VA. That's correct.
Okay. So 3 questions from Dr. Ockley. Given the rapid increase in the number of devices of variable accuracy/quality, how do we keep pace with this? And how can we trust devices when most of the data comes from the manufacturer? That's question number 1. Go ahead.
I'll say that's the job for the Emerging Technology Committee. We're trying to do the best we can to screen as many devices as we can. We're assigned to review 1 device every month. It's fairly difficult, but we try to review as many as we can. But there are just too many out there. It's very difficult to be able to review all of them.
Right.
Especially, so we're basically focusing on FDA cleared devices or FDA registered device. We're focusing on the device we believe will be helpful for clinicians. So we try to be a little bit more focused on these devices.